Thank you, Ramsali. So I'm going to discuss the recurrence of the disease post-transplantation. So as we know, glomerular nephritis is one of the main cause of end-stage renal disease, and it ranges from 10 to 38 or 40%. But in post-transplant scenario, recurrence of the disease is third most common cause of graft failure, mostly after 10 years of the transplantation. But the incidence, pathogenesis, natural course of recurrence are still not completely understood. So the diagnosis, management of recurrence are important for optimizing graft survival and analyzing the pathogenesis of native kidney disease. So coming to the definition of the recurrence. So what is true recurrence? True recurrence is that when the native kidney disease and transplant kidney disease are the same, and they should be the biopsy proven. And the de novo disease, when the biopsy proven kidney disease that occurs in transplant kidney is different from the native kidney disease. So kind of new occurrence of the disease which is not same as the native disease is called as a native disease. But as we know that most of the time the patient present as a CG and CKD and we do not know the native disease. So in that scenario, it's very difficult for us to manage to diagnose is whether it's a recurrence or to denote the disease. So it is known as a transplant glomerular nephritis with primary or unknown primary disease. But one should try to differentiate this both recurrence versus denote disease. Now the data regarding recurrence of glomerular disease is very limited, but reasons for that, because as I said, native disease biopsy is not, we are not available, have the biopsy reports. But in post-transplant scenario, routine urine examinations are not performed. This is for the clinicians. In most of the center, if they do the routine urine examination, we can pick up the proteinuria, hematuria, or anything else which can help us for the diagnosis of recurrence of the de novo disease. And some centers, only one core is taken, so IF and EM is not taken. Nowadays, paraffin-induced IF and EM is also available, but that is not in all the centers. And last, one of the important thing is protocol biopsies. This protocol biopsy is not performed in most of the centers. They are debating that why should we go with the protocol biopsies. But it is very helpful for early detection of the disease. So this is list of disease which has a recurrence. As you know, the Rens deposit disease, a high recurrence, up to the 100%. IgA nephropathy range is very high, 20 to 60%, 50%. Membranous up to 30%. Diabetic more than 50%. MIDD 70 to 85%. Fibrillary GN again more than 50%. And one of the important disease is primary hyperoxaluria, which has high recurrence up to the 100%. And the graft loss is very high, up to the 90%. Atypical HUS is again the very high recurrence, 30 to 80%, and graft loss is up to the 50%. If you see the pathophysiology of this recurrence of the disease, one of the important factors is circulating factors. Like whenever there is circulating permeability factors are in the circulation are there, it leads to primary FSGS recurrence. Autoantibodies, whenever there is anti-GBM antibodies are present. Nowadays, they are not doing the anti-GBM antibodies are present in transplantation, but if it is done, that can lead to the recurrence of the disease. Complement abnormalities. If there is dysregulation of the complement, like alternate complement pathway, it can lead to C3 glomerulonephritis, dense deposit disease. If genetic mutations are there, it can lead to atypical HUS because there are high mutations are there. And classical pathway, immune complex disease, IgA nephropathy, lupus nephritis, lectin membrane pathway can lead to the membranous nephropathy. So now we will see some overview of cases. In morning, Dr. Bhavana has already discussed few cases. I am repeating these all cases again. So this is kind of 31-year-old male who was living donor renal transplantation 6 years before transplantation. His serum creatinine was 1.7. He has presented with a nephrotic range proteinuria, and his primary biopsy-prone disease was the membranous nephropathy. So here you can see there is thickened GBM in glomeruli. You can see few spikes on the silver stain over here. And there is, when we saw the C4D, it was negative in the PTC, but there was granular C4D deposits along the GBM. Again, it can hint you that it can be a membranous nephropathy. So when we saw the IF, it was strong IgG deposit along the GBM. So here we called as a membranous recurrence of the disease. Then we did the anti-PLA2R, which was strongly positive along the GBM. And EM was showing some subepithelial deposits, which confirms the membranous nephropathy. So now the question is how to differentiate recurrence versus de novo disease. Generally, serum anti-PLA2R antibodies are negative in the de novo antibody membranous nephropathy, but in 70% of the recurrence of disease, you will find PLA2R positivity, and it is IgG4 type. What happens when you see the early membranous recurrence, you will not find any changes in the glomeruli. They are kind of unremarkable. But immunofluorescence, IF will show strong positivity, that is IgG, kappa lambda, and C4D. And idiopathic membranous nephropathy has a recurrence of more than 40% with graft loss up to 10 to 15%, 10 years. And it is also seen that higher recurrence recurs seen in the post-second transplantation, and patient present most of the time with a nephrotic range proteinuria. In this next case, 25 years male with living donor renal transplantation. His serum creatinine was 2.9, proteinuria very high, 13.2. He was on triple immunosuppression. Basic disease was IgA nephropathy. And this biopsy was performed at almost 5 years post-transplantation. Here you can see there is cellular crescents. The crescent was circumferential, almost 70 to 80% Bowman space was covered by this cellular crescents. And there was mesangial proliferation, M1 you can say. Segmental sclerosis was there, and hilar vessel was showing the hilar arteriolosclerosis. C4D was negative. And on IF, there are strong IgA deposits, predominantly in the mesangial region, where intensity was almost +3. And with that, C3 was also having the similar kind of intensity, +3 intensity in the mesangium. Kappa and lambda was somewhat lesser intensity. So it's compatible with the IgA nephropathy. Now the question is that whether it's a recurrence or de novo. As the patient has already IgA nephropathy, so we called it as a recurrence, but sometimes it's very difficult for us to differentiate IgA recurrence versus de novo disease. So recurrence rate generally range from 9 to 61%. Why the range is so high? See, some of the centers have the policy of the protocol biopsies. So they can pick up the IgA nephropathy at a very early stage. Histological recurrence and clinical recurrence both are different. Histological, you may get the IgA deposits, but in clinical scenario, you will get the proteinuria, hematuria, or the renal function dysfunction at a later stage. And we should also report as Oxford classification because it is very important for the prognostic value. That's why the Oxford is used in post-transplant IgA nephropathy also. So this is a comparison between recurrence versus de novo IgA nephropathy. You can see that mesangial hypercellularity, endocapillary hypercellularity, presence of crescent, and C3 staining. If it is high and with the proteinuria, it is suggestive of more over recurrence than the de novo disease. As such, recurrence disease is more inflammatory, more aggressive, with a worse outcome. So this case is, because they have all the crescents for there, so most of the time it is recurrence. So risk factor associated with the recurrence, it could be recipient associated, donor associated, or the transplant associated. In recipient associated, whenever there is high serum IgA level, young age, rapid progression to ESRD, and high degree of proteinuria, which is have a high risk of recurrence of the disease. In donor-related, living donor, zero HLA mismatch, and a specific HLA isotype like DADQ has high risk. In transplant-associated, whenever there is increasing time after transplantation, it leads to high recurrence. But if you're using the steroids, that reduces the recurrence chances. Another case, 9 years male, presented with the disease from the transplantation with 3+ proteinuria, and his basic disease was FSGS. And the biopsy performed 3 years post-transplant. Here you can see again that there is FSGS. Segmental sclerosis was seen over here in PAS and GT stain. So it was kind of FSGS. It's very simple to diagnose. But sometimes what happens, you will not get proper FSGS. Because in early cases, you will not get any lesion. So in that scenario, EM will be helpful. You will get the podocytopathy, that is a full effusion of the food process, diffuse food process effacement, and the diagnosis of recurrence of the FSGS. So in early recurrence can happen within 2 to 3 days or up to 4 to 6 weeks post-transplantation. Late recurrence can be seen up to the months or years after transplantation, and it can lead to graft failure up to 20 to 27%. In early recurrence, there is histological lesion may not be present, but a later stage you will get the lesion. And in that scenario, EM will be helpful because there you will find the diffuse food process effacement. So there are a few risk factors like humoral permeability factors whenever they're in circulation that can lead to the high recurrence. Younger age, because the age of the recipient is less than 6 years, have the high recurrence. Presence of mesangial hypercellularity in native disease that reflects a more severe form of disease. Rapid progression to ESRD, steroid resistance, older donor, pre-transplant bilateral nephrectomy, because the native kidney seems to be an absorber of the permeability factors. So if the bilateral nephrectomy is done, that can lead to the more chances of recurrence of the disease. Then recurrence in the previous transplantation, if there is presence of super in the circulation, that can also lead to development of the recurrence. High degree of HLA match also have the risk factors, and familial variant of FSGS has the better outcome. So whenever there is familiar variant, it has a good prognosis. Next case, 42 years male, living donor renal transplantation. Father is a donor, and chronic HUS, native kidney disease. So here you can see this is a glomerular. I have the dilated lumina filled with the thrombi, mesangial lysis, duplication of the membrane, and the artery also having the mucointimal proliferation and some biointimal proliferation. So the kind of typical HUS you can see. But the diagnosis is not important morphological, but whether it is related with the ABMR, CNI toxicity, recurrence of disease, or any infection related, that we should differentiate. Already Dr. Bhavna has mentioned so in the morning that when for the ABMR, you have to check for the DSA, CF4D, CNI induced, you have to check for the CNIT induced halinosis, other features, and you should also check for the label also. And for the recurrence of that, you should go for the complement lab genetic mutation HI, you have to check for that. So recurrence rate in HUS, 60%, graft failure is more than 90%, and whenever there is HNI mutation, it has a bad prognosis. Other factors like infection like CMV, influenza, parvovirus, B19, BK virus, they all can lead to this TMA formation. And can present as hemolytic anemia, thrombocytopenia, acute kidney injury. Another very important case is the recurrence of oxalosis. So this is the case whenever the primary hyperoxaluria is there, it is 100% recurrence rate as there. You can see the tubules are filled with the fan-seb, or there is some crystals are seen over, they are birefringent of polarized light. So whenever there is enzyme mutation is there, PH1, primary hyperoxaluria is there, in that case, you should go for the double transplantation, as Sita was saying. kidney or liver transplantation. If you not go for combined transplant, there are 100% chances of recurrence of the disease. Next case, 25 female, living donor renal transplantation, lupus nephritis. So here you can see that glomeruli has the thickened basement membrane. So it is kind of membranous pattern. And the eye was showing diffuse or full house positivity, strong IgG, C1q deposit, along with IgA, IgM, C3, and kappa and lambda. And on EM, there was epithelial deposits. So basically, it's a recurrence of the membranous lupus nephritis. So histological recurrence, generally it is seen in 30 to 50%, but the clinical recurrence is less than up to the 5%. So most of the time there is histological recurrence, and the graft loss is not seen at most of the time. And patient can present with proteinuria, mild proteinuria, hematuria, rash, arthralgia, and if you go for a protocol biopsy, there are always chances of picking up the disease early. And EM may be helpful for picking up the disease. So if it is there, then generally it is a mild disease, like mild gingival proliferation, membranous nephropathy is there. You will not get very severe form of disease in the lupus recurrence. Risk factors: African male, female recipient, younger age, patients with antiphospholipid antibodies, hypercomplementemia, presence of lupus anticoagulant, live donors. These are all the high risk factors which can lead to development of recurrence of the disease. Next case, 18 female, deceased on renal transplantation, native kidney disease was C3 glomerulopathy, and patient presented with the urine protein and serum C3 low level. This was 8 months post-transplant biopsy. Here you can see the biopsy was showing the MPGN kind of pattern, mesangial hypercellularity, endocapillary hypercellularity, membrane was thickened, split membrane, and silver was showing some non-argyrophilic, silver negative type of pattern. And there was severe, strong C3 deposit along the GBM was seen in the IF. C40 was negative. So, and on EM, there was dense osmophilic intramembranous lamina densa was completely replaced by the deposit that is the dense deposit disease. Even the mesangial deposits, subendothelial deposits were also seen. So it's a recurrence of the dense deposit disease. See, dense deposit disease has also very high recurrence up to the 100%, and the graft loss is but very less, that is up to 25%. And time of recurrence may be seen 2 weeks to 5 years, and mostly the patient present with the proteinuria, hematuria, low serum C3 level, and sometimes they may be associated with the ABMR. The etiology or risk factors are very poorly known, and yes. But if you compare with the C3GN versus dense deposit disease, the recurrence rate is more in the dense deposit disease, but if you see the graft loss is more in the C3GN. Here you can see the more than 50% graft loss in 5 years in the C3GN versus dense deposit disease has the almost 25%. And the recurrence rate is almost 100% in the dense deposit disease versus 30 to 50% in the C3GN. Other secondary GN like POSIMIN had the recurrence rate is 17%, but the graft loss is 7% up to anti-GBM disease, as I already discussed. So this is our data that we have done almost 3,739 patients transplantation, almost 11 years. And the total post-transplant glomerulonephritis was 172, that is 4.6%. And out of that, recurrence was seen, the true recurrence, 48%. And de novo in 53 patients. And the disease with unknown primary etiology was 71. And this is the bifurcation of the disease. IgA nephropathy was the most common recurrence, what we found, that 14 patients, followed by the membranous, FSGS, diabetic nephropathy. And in de novo, FSGS was the most common disease. If you see that recurrence of time recurrence, that was a 3.7 years, which is a mean transplant recurrence of the disease versus 4.6 in the de novo disease. Creatinine 2.3 comparable, and protein was somewhat higher in the recurrence of the disease. This is again the bifurcation of all the disease. The mean urine protein was high in the 7.7 in the FSGS, and the time since the transplantation is less in the FSGS, the 0.9 year, less than 1 year. And this is another study done by the CMC Vellore. They have also the IgA nephropathy recurrence. They have done the 5-decade study. So if you go for the graft dysfunction or loss, there are different, these are main causes. One of them is the recurrence of the disease. So concluding, recurrence GN adversely affect the graft function. Allograft biopsy still remains the gold standard for the morphological changes. And urine analysis is very important and should not be ignored. IEF and EM study is also very helpful to pick up the disease. Protocol biopsies, again, very, very helpful. So one should adopt that policy, and we should maintain national, international registry should be developed. So renal graft is an important position of the patient as well as clinician. Accurate diagnosis is the heart of clinical management of a patient with graft dysfunction. Thank you very much.